Okay. A pleasant good afternoon to all of you. I hope you saw the slides and thank you for a very excellent lecture. We're going to be talking about basic mechanical ventilation for this afternoon. I hope you learned certain things and hope to see you again in the question and answers, and we can probably elucidate some things. So basic mechanical ventilation. I'm from Cebu City. I hope everybody's fine in Manila. Something's wrong. The objective of the lecture is to talk about the indications of the mechanical ventilation, to distinguish different types of breaths and modes of mechanical ventilation, to talk about initial ventilator settings for specific circumstances, and we're going to talk a little bit about weaning from the mechanical ventilator. So what are the indications of putting somebody on a mechanical ventilator? So there are two usual indications. One is the patient has hypoxemic respiratory failure. That is, the patient develops refractory hypoxemia despite putting them on high flow oxygen or non-rebreather mask, then you'd probably need to put them on a mechanical ventilator. The second reason why we put them on a mechanical ventilator is if they develop hypercarbic respiratory failure. That is, that usually happens if they have a decreased ventilatory drive, that is like an opiate overdose where the patient is not breathing. There is a respiratory muscle dysfunction, that is patients with respiratory muscle fatigue, chest wall abnormalities, neuromuscular disease like ALS, patients who are not able to breathe on their own because of muscular dysfunction like myasthenia, which is a nerve dysfunction. Or it could be hypercarbic respiratory failure, could be secondary to increased airway resistance and or obstruction. Wherein the minute ventilation is actually normal, the patient is breathing fast, but actually the effective alveolar ventilation is inadequate to meet demands. The reason for this is there's a lot of dead space ventilation or a lot of wasted ventilation. The patient is breathing really fast, but only a small percentage of actually alveolar is actually participating in the breathing, thus it causes an increase in carbon dioxide. And we see that in a lot of our asthmatic patients and COPD patients. But aside from hypoxemic and hypercarbic respiratory failure, the other indications for putting them on the ventilator includes controlled hyperventilation. That is in patients who are herniating, then you need to hyperventilate them, or patients with severe metabolic acidosis where you want to hyperventilate them to normalize the pH. In patients as well, we want to reduce the work of breathing in conjunction with endotracheal tube for airway protections. So somebody cannot protect their airways, very comatose, so probably put them on endotracheal intubation with a mechanical ventilator. It is also indicated before essential diagnostic therapeutic studies if it appears that respiratory failure may occur during these maneuvers. Usually we see this in stroke patients where we want to send for an MRI, or patients who are vomiting so much blood, where it's best to secure the airway and make sure the respiratory system is adequately controlled before we go for more diagnostic and therapeutic interventions. And lastly, we sometimes put them on a mechanical ventilation to improve the pulmonary hemodynamics in patients with post-operative pulmonary hypertension. So when we put somebody in a mechanical ventilator, they should be comfortable after you put them on. They should not be struggling for breath. The goals of mechanical ventilation is one, improve the oxygenation. Second, adjust alveolar ventilation. That is, we look at the PaCO2 and the pH and decrease the work of breathing and assurance of patient comfort and synchrony with the ventilator. This is when you know that the patient actually you're doing well with the ventilator, when the patient is synchronous and more comfortable with the ventilator. There are different types of ventilator. In the past before, during the time the polio epidemic, we have negative pressure ventilators, wherein the patients are actually placed into a machine where air is sucked out, so the patient's chest wall expands. The problem with this is that there's a difficulty with clearing secretions and it became unpopular. This is the reason why we do positive pressure ventilation. What do we mean by positive pressure? We push air into the endotracheal tube. Remember that when we ventilate somebody, we ambubag, we push air in. So that is called positive pressure ventilator. Aside from the invasive positive pressure ventilator, we also know that we also have what we call non-invasive positive pressure ventilation. This is when we administer ventilatory support without using an artificial invasive airway. That is, we don't put them in an endotracheal tube or tracheostomy tube. So here you can see a critical care ventilator attached to a full face mask. Here it's just a regular BiPAP machine where you can actually use this as well for our COPD patients or sometimes with congestive heart failure. In the COVID pandemic, I know this has been used in some centers, though some centers are more careful because of the aerosolization involved with this. In order to better understand the modes of what we're really talking about the ventilator, when we say ventilator modes, we need to understand terminologies. So this is very important. And I will try to explain this carefully. Trigger. Trigger. What does a ventilator sense to initiate an assisted cycle? When you're ambu-bagging somebody, what triggers you to ambu-bag? It is when you see the patient taking a deep breath, then you bag. But the machine cannot see your patient taking a deep breath. How do they know that the patient is initiating a breath? They will know by detect an inspiratory effort. The way that they detect an inspiratory effort is either a change of flow, that is, they detect a change of flow or a change of pressure. So there's a change of flow or a change of pressure to the ET tube. Then the machine detects that and it gives a ventilator breath that triggers it. The second thing that can trigger a machine is a time-based signal. You have a backup rate. If the patient is not breathing at all and you put a backup rate, a certain time the machine detects that there is no breath involved, it will trigger the ventilator to give a breath. So trigger. What does a ventilator sense or trigger it to give a ventilator? Cycle is another word we use. Cycle is factors that determine the end of inspiration. What cycle is? What terminates the breath? So we have volume cycling. If a certain amount of volume is given, then the ventilator will stop. Time cycling is it gives a certain amount of time of breath and it stops because that's how you set it. Flow cycling is in pressure support. That is, if the machine detects a flow less than 1/3 of the original flow, then it will stop giving a breath. So cycles is what makes it stop breathing. Then we also put limiting factors. What do we mean by limiting factors? These are operator-specific values that such as airway pressures, alarm limits, that are monitored by transducers internal to the ventilator circuit throughout the respiratory cycle. If the specified values are exceeded, the inspiratory flow is immediately stopped. So these are the things that we set that limits so you don't have barotrauma, you don't have any problems with the ventilator because the machine does not think. It only runs as well as the operator. So again, trigger is what starts the ventilator. When we say what triggers the ventilator, what starts the ventilator. Cycle is what stops the ventilator. How does the ventilator stop giving a breath? Of course, when you give a breath, you have to stop. So that's a cycle. And then limiting factors are the limits that we set. What are the peak airway pressures that we set? What is the backup rate? So there are certain limits that we put in the ventilator that it doesn't go through certain pressures or certain volumes that we set. So again, the other thing, so we talk about cycle, trigger, and limiting factors. I hope you understand that because it's very important in the succeeding slides. The type of ventilator breath is also very important. When we say volume cycle breath, we're actually giving a certain amount of volume. So that is the volume we're delivering. For a volume controlled breath, it is the delivery of a preset tidal volume. When we say volume controlled breath, we set a volume of 400 cc, it will give 400 cc. The tidal volume and inspiratory flow rates are the independent variables. So these are the ones that you set. While the peak inspiratory pressures are the dependent variables. So in volume control, you set the tidal volume and the inspiratory flow rate. For time cycle breath or pressure controlled breath, we deliver a constant pressure for a preset time. So cycle, as we mentioned, time cycle. This is the time cycle is what stops the breath. So for the certain amount of time it's given, the breath stops. It gives a delivery of a constant pressure for a preset time. This is why we call time cycle. In this case, because we set the pressure, the tidal volume and the inspiratory flow rates are the dependent variables. And the independent variables that we set in the machine are the peak inspiratory pressure. Okay, so volume control and pressure control. If you notice, this is Boyle's law. Boyle's law is pressure is inversely proportional to 1 over volume. So the higher the volume, so it means that the volume and the pressure are inversely proportional, but they are related. So changes of volume will lead to changes in pressure, which is inverse in relation. Flow cycle breath, as we mentioned, as we talk about in pressure support, is similar to a time cycle breath, except it stops giving a breath when the flow decreases to a predetermined percentage of the initial flow rate, around 25%. This is in patients who are breathing spontaneously. In some machines, you can actually change the predetermined percentage of the initial flow, 20, 30, 40, depends on how the patient. But the default setting for all your pressure support is a 25% flow rate decrease. So Boyle's law, again, volume is volume controlled breath. That's a volume you set. For a pressure controlled breath or time cycled breath, you set the pressure. And again, to reiterate physics, I hope you remember physics, for pressure is inversely proportional to your volume. Or pressure is equal to 1 over volume. So let's take a look at the graphs for volume control. This is pressure here over time. This is flow over time. So when you have a volume controlled breath, as we mentioned, the flow and the volume are independent variables. You can set a peak flow and you can set the volume. As you can see here, the triangles are the same because this is what you set. The pressure is dependent on your compliance. If the compliance decreases, the tidal volume remains the same, but the pressure increases. What do you mean by that? If you have a stiff lung, less compliance, stiff, very stiff, you're giving a same volume, what happens? The pressure increases in the smaller container. Thus, you may be able to deliver the volume, but as the compliance decreases or the lungs get stiffer, then the pressure increases. This is why sometimes in volume control ventilation, we see peak airway pressure alarms, because as the compliance decreases, then the pressure will also increase. Time cycle breath or pressure controlled breath, as we mentioned, is the independent factor is we set a certain amount of pressure for a certain amount of time. So actually the pressure over time curve here is the same. So take a look here, pressure and time is the same because this is the independent variable. In contrary to volume control, when the compliance decreases, that is the lungs get stiff, so you're delivering the same amount of pressure, what happens? Because the pressure cuts off, then there is a decrease in volume and flow, opposite. So the dependent variable for a pressure controlled breath is your volume. As the compliance decreases or the lungs get stiffer, the flow and volume changes, it actually decreases. Okay, so remember that. So one or the other, it's opposite. If you set pressure control, then the volume may drop if you're not careful. If you set the volume control, you set a tidal volume, the pressures may go up as the compliance decreases. So let's take a look at this. What is volume ventilation and what is pressure ventilation? And again, I put Boyle's law here. I hope it sticks to your mind. As we know, we keep repeating things and we keep forgetting. So for volume ventilation, volume delivery is constant. For pressure ventilation, the volume delivery varies. As we say, volume is dependent here because in pressure control ventilation, it's the peak pressure that is constant. We deliver the independent variable is pressure for pressure control, while in volume ventilation, the independent variable is volume. So you can see with volume ventilation, the peak pressure will vary, while in pressure ventilation, the volume delivery will vary because that is the dependent variable. Again, the inspiratory flow is constant because you actually set the flow rate in volume ventilation. For pressure ventilation, it actually has one of the highest flow rates. Inspiratory flow varies depending on the need of the patient. And that is why in some patients, actually, when you put them on pressure controlled ventilation, they're more comfortable because it gives higher flow than what you're setting. So the inspiratory time is determined by set flow and tidal volume. So the higher the tidal volume, it takes the longer ventilation time to give the volume. The faster the flow, then the shorter the inspiratory time, right? You give the volume higher, faster, then the inspiratory time is decreased. While with pressure ventilation, as we said, it's a time cycled breath. So this is set by the clinician. In most ventilators, it's not really the time, but you can set the A ratio, 1:2, 1:3. But in pressure ventilation, inspiratory time is set by the clinician. I hope you understand that. Okay. This is our ICU. Okay, so this is the ventilators we use. We're fortunate that we have the Hamilton G5 and we use it intensively in all of our patients. And this is actually our COVID ICU, if you notice this. And we were able to move our ventilators outside the room where the patient is intubated actually. The compressor is in, but the monitor is placed outside. So to try to decrease the exposure of healthcare workers to COVID, as we always do this right now. So let's take a look at the panel in our patients of the G5. So if you can take a look here, it comes up with several modes actually. But what is important in most machines is this top four. So in the left side is pressure control, that is P, pressure controlled CMB, pressure controlled SIMB. While here in the other mode, this is volume control. In Harrison, you may be confused because where they're talking about CMV, they're talking about volume control. So here it's volume control, CMV, volume control, SIMV. These are other modes that are available in the ventilator. I don't think we should discuss this. This will be too intensive, will be too long. SPONT is usually pressure support. And we also have an NIV, non-invasive ventilation, and NIV spontaneous time mode in the ventilator. We can also do high flow with our ventilators as well. And these are the settings that usually, and we'll discuss this later. So these are the alarm limits that you put. In this instance, this is volume controlled mechanical ventilator, and that is why you can set the tidal volume, the backup rate, and the PEEP and the FiO2. We'll talk more about that later. This is also one of the more popular ventilators that are available. This is the Puritan Bennett. So I'm going to show you how the interface also works with the Puritan Bennett. So with the Puritan Bennett, we're going to pay a closer attention to this panel over here. So I blew this up. So with this panel, you can see with the mandatory type, you can actually pick either volume control or pressure control. Okay, VC plus is a combination of both volume and pressure, where it's a volume assured pressure control ventilation. But anyway, this is volume control and pressure control. Okay, so mandatory type, we talk about, so hopefully you understand what we mean by VC and PC. In the same way as well, here in the mode, you can actually set what type, either volume control or pressure control, but you can put the patient either on assist control, SIMB, spontaneous, or bi-level. Okay? So let's discuss. These are the ventilator modes. So assist control mode ventilators, some would say CMV, but actually it's really assist control because the machine actually listens to the inspiratory effort of the patient. SIMV is synchronized intermittent mandatory ventilation. Cpap is continuous positive airway pressure ventilation. Pressure support ventilation is a spontaneous mode for some ventilators. So let's start with the assist control mode ventilation. Assist control mode ventilation delivered with either volume cycle or time cycle. So as we mentioned, you can either do AC mode with volume cycle or time cycle, or volume control, pressure control. You saw that with the Puritan Bennett. With the G5, it's two panels. Okay? What triggers the machine? What causes the machine? What starts the machine? It's the patient's inspiratory effort. If no patient effort is detected within a specific time window, a breath is given by a timer signal within the ventilator. This is the reason for the backup rate. If the ventilator does not detect a breath for 10 seconds and the backup rate is higher, then it gives a breath. The rate is determined in assist control mode ventilator either by the patient or the operator specified backup rate, whichever is of higher frequency. So if your backup rate is 16, but the patient is spontaneously breathing at the rate of 20, the machine will detect the 20 and will assist 20 breaths. If the machine does not detect a breath or the patient's apneic and your backup rate is 16, then the machine will assure you that there is going to be 16 breaths. And this is the reason for calling it a backup rate. So this is a diagram. So in this case, this is a patient on assist control. Here, the patient, there is an inspiratory effort, a change of flow or a change of pressure. So the machine detects a breath, it gives a breath. This is assist control. Here, the machine again detects a breath, it gives a breath. So for every effort, the machine gives a breath. If the machine does not detect a breath at all for a certain amount of time, then it will give a controlled breath or a backup rate. Okay, so I hope you understand. This is a volume cycled ventilator. That is volume cycled. Every volume is the same. Pressure limit is we set the peak airway pressure limitations where a limitation is reached and the volume cuts off. Okay, so we saw that. With assist control mode ventilation, the advantage is the work of breathing is significantly reduced. This is what we do with our ARDS patient. Every breath is given. The disadvantage with this is that respiratory alkalemia can occur in patients who are breathing fast, probably to non-respiratory or non-metabolic factors, such as anxiety, pain, or airway irritation. The patient is just anxious, so he keeps giving a breath. The machine will keep giving a breath for every effort the patient does, and sometimes we need to do sedation. With the problem of giving a breath when the patient is tachypnic, it can cause dynamic hyperinflation or auto-PEEP. We'll talk about that later. But auto-PEEP is basically taking a deep breath and you're not able to exhale out. When that happens, it limits the venous return because of increased intrathoracic pressure. It causes decreased cardiac output, increased airway pressures, predisposing to barotrauma. So how do we detect auto-PEEP? So in this case, you can take a look here in the volume control where you take a look at the flow over time curve, and you can see that the exhalation should go back to zero. So zero flow at end exhalation indicates equilibrium of lung and circuit pressures. There is auto-PEEP if the flow does not go back to zero. That means the patient is not able to exhale all the air out. Before they are able to exhale the air out, another breath is given. And that is what we mean by auto-PEEP. It's a PEEP that is given, extrinsic PEEP. It's not PEEP that we set, it's PEEP within the body in this case, because the patient is not able to exhale all the air out. So the transition from expiratory to inspiratory occurs without the expiratory flow returning to zero, as you can see here. Unlike here, it goes to zero. In this case, if you see this, that means that there is an auto-PEEP. So in this case, if this patient develops auto-PEEP because of tachypnea, what can happen is that the patient will increase their intrathoracic pressure. So you just imagine, inhale, you're not able to exhale the air out, and to inhale again. And then what happens if the machine keeps doing that, then it causes a barotrauma and a pneumothorax. So we have to be very careful with auto-PEEP, and we have to watch that carefully. So let's talk about synchronized intermittent mandatory ventilation, or SIMV. SIMV delivers either volume cycled again, so you can see SIMV mode with either pressure controlled or volume controlled breath. With the SIMV, it delivers a preset mandatory number of breaths per minute. Okay, so if you set as SIMV synchronized intermittent mandatory ventilation of 8, it will only give you 8 breaths. In between, if the patient's breathing faster, it will just allow the patient to breathe spontaneously without delivering a ventilator breath. So if I set as SIMV of 10 and the patient's breathing at the rate of 20, 10 of them will be machine breaths, while 10 will be spontaneous breath on their own. So SIMV 10. How about if the patient's not breathing? So patient's apneic. If you set as SIMV 10, it will give 10 as well. Okay, so SIMV rate of 10 is what, if you say SIMV rate, whatever rate you set is what the ventilator will give. That is the mandatory rate of breath. It will try to synchronize in the patient's inspiratory effort, okay, at a frequency determined by the operator. Only the preset number of breaths is ventilator assisted. So remember that. There's a difference between assist control and SIMV. I hope you understand that. So in this case, if you set lower SIMV rate compared to the spontaneous breath, example 11 is your SIMV, the patient's breathing 20, then 9 will be spontaneous. Like in this case, the patient's breathing spontaneously, then the machine kicks in. If the ventilator does not determine the breath and the set limit, you put a backup rate of 10, then it will assure you that the patient will have an SIMV rate of 10 or a ventilator rate of 10. If you set SIMV 4, so the patient will just receive 4 breaths, whether the patient's breathing 20, 30, 40, 50, or the patient's breathing 0. It will continue to just give 4 breaths because that is the preset number of ventilation you're giving. The advantages of this, it allows the patient to assume a portion of their ventilator requirement, that is spontaneous breathing. With assist control, you cannot wean the patient because the patient is being ventilated every time they take a deep breath. The disadvantage is it's associated with a greater work of breathing than assist control because they have to assume some of the work of breathing. Okay, so we're on the third mode of ventilator, continuous positive airway pressure. Continuous positive airway pressure, or CPAP, pertains to the application of a constant positive pressure throughout the spontaneous ventilator cycle. So that is continuous positive airway pressure. No mechanical inspiratory assistance is provided. It requires that the patient is breathing on their own. If the patient is not breathing, it will not give a breath. All ventilation occurs through the patient's spontaneous effort. It has the same physiologic effect as PEEP in a patient on the ventilator. Okay? So the advantage of CPAP, it may decrease work of breathing. We use CPAP in our patients with sleep apnea, in patients with congestive heart failure. The tidal volume and rate is determined by the patient. If the patient is not breathing, the machine will not give them a breath. It also often the final form is support before extubation. So let's say here the patient is breathing spontaneously. If you put a CPAP of 10, then the whole breathing pattern is actually increased by 10. So this is CPAP of 10. You're breathing in and out a certain level. So here you see that the level of CPAP, you raise up the airway pressure, and there is inspiration, expiration. And the amount of tidal volume is all spontaneous. It depends on the patient's effort. As we mentioned, CPAP and PEEP is the same. When we usually say PEEP, positive and expiratory pressure, this is what we actually set on the ventilator. CPAP, we usually mean that when the patient is spontaneously breathing or not on a mechanical ventilation. PEEP is application of constant positive pressure such that at end exhalation, airway pressure does not return to zero. So as we said with auto PEEP, they're not able to exhale all the air out. With PEEP, it's a certain number that you set. You set a number of 5, they inhale, and they can only exhale up to 5. So that's a PEEP of 5. They exhale only to a certain number that you set. It is used with other mechanical ventilator modes, so you can combine that with AC, SIMV, or PCV. If you use that with spontaneous mode, we usually call it CPAP. The advantage of this, it increases the functional residual capacity and improves oxygenation. It recruits collapsed alveoli, it splints and distends the patent alveoli. So as we say, when you take a deep breath and when you exhale, you put PEEPs, it doesn't collapse all the air out. It is also useful in patients with congestive heart failure because it redistributes lung fluid from alveoli to perivascular space. So this is an example of PEEP. So you can take a look here. When a PEEP was set, you can see that the breathing was actually elevated above a certain number when the PEEP was applied over here. So patients' expiratory effort cannot exhale all the way to zero because we put a positive end expiratory pressure. So let's talk about pressure support ventilation. Usually we use this with the newer ventilators. Almost all ventilators have this now. We use this for weaning extensively. So it provides a preset level of inspiratory pressure assist with each breath. All breaths are flow cycled. As we mentioned, flow cycle, when there is a certain amount, 1/3 of the flow is detected, then the machine cuts. Okay, it doesn't give any flow anymore. Specifically designed for use in weaning process, the inspirator phase is terminated when inspirator airflow falls below a certain level. Usually 25% is the default. Patient receives ventilator assist only when the ventilator detects an inspiratory effort. In pressure support ventilation, if the patient is not breathing, it will not give a breath. It has to be a spontaneous effort. It can be used in combination with SIMV. That is, in spontaneous breath, they can have a pressure support, just enough to counteract the resistance of the tube. The set amount of pressure support that is applied augments each patient-generated breath. Usually, the suggested pressure support setting is enough to maintain a 6 to 10 ml per kilogram. So you set your pressure support to go up to look at your tidal volume. It is slowing of spontaneous respirator an acceptable rate and the desired minute ventilation. This is the pressure setting you usually put on board. Okay. So again, pressure support is patient triggered. The patient has certain effort. Flow cycle because it's usually 25% of flow. Pressure limited because we set the amount of pressure support 5, 7, or 10. Then depends on how the patient breathes. Longer inspiration, they have better volumes. Okay, and then it cycles when there's no more flow. So this is pressure support ventilation. The advantages of this, it allows comfort and better tolerance. It is a winning mode. It allows us to decrease the amount of pressure support as the patient's breathing. The disadvantages, it cannot be used in patients with apnea, but most of the ventilators right now has an apnea backup. So in patients who put in pressure support, if they go into apnea, then the machine will kick in and put them on SIMV or AC depending on the default setting you put. There can also be inappropriate cycling with bronchopleural fistula or ETT cuff leak, because what happens, it cycles when there is a decrease of flow. But if there's a leak somewhere in the system, then it cannot determine that the flow decrease is because of a fistula through the chest tube or because of the cuff leak. So that's a disadvantage of this. Initial ventilator settings. So we talk about the different modes of ventilator. Let us look at practical approaches on what to do for the ventilator. So we choose the ventilator mode which we are most familiar with. Okay, that's the first thing we rule. The initial FiO2 is usually 100%, or we adjust to our saturation monitor. The initial tidal volume usually is set at 8 ml per kilogram. In patients with neuromuscular disease, sometimes they require 10 to 12 ml per kilogram because of air hunger. Okay, they feel that they need more breath. In ARDS, we have to put them at 6 to 8 ml per kilogram of ideal body weight to avoid high inspiratory plateau pressure. The plateau pressure that we have to limit them, it has to be less than 30. It has to be less than, to avoid greater than 30. Okay. Choose respiratory rate and minute ventilation appropriate for this particular situation. In this case, we should always target the pH. If the PCO2 is high, that's not a problem. The pH is more important. That is where we usually adjust our ventilator setting. Minute ventilation usually 7 to 8 liters per minute, but in septic patients where there is a lot of carbon dioxide that is released because of metabolic stress, you may need to increase the minute ventilation. In patients with COPD or asthma where there's a lot of dead space ventilation, wasted ventilation, then you may need to increase the minute ventilation as well. Use PEEP in diffuse lung injury to support oxygenation of FiO2. We set the trigger sensitivity to allow a minimal patient effort to initiate inspiration. Again, it's usually inspiratory, it's either pressure or flow sensitivity. So usually the lower the changes of flow, the more sensitive. So a little bit of flow, the machine can detect that. But if you put it too sensitive, that is just a small, there's a danger that the machine will keep auto-cycling because of the changes of flow or pressure because of secretion. In patients at risk, avoid choosing ventilator settings that limit expiratory times or cause or worsen auto-PEEP. You have to be watched out for auto-PEEP when we do this in patients with COPD and asthma. Patient intolerance of ventilator settings can lead to poor oxygenation, inadequate ventilation, or excessively high peak inspiratory pressure. When the correct ventilator settings are placed, if the patient is still uncomfortable, then consider sedation, analgesia, or neuromuscular blockage. But you should work on your ventilator first before you sedate them. Most often, they can be comfortable with the correct settings. So let's talk about some guidelines on what the different, this is just a brief summary. In patients with ARDS or acute lung injury, this is what we see with COVID right now, so diffuse bilateral infiltrates. What we need to do is you need to put them on low tidal volume, 6 to 8 ml of kilogram of ideal body weight. Maintain inspiratory plateau pressure less than or equal to 30, permissive hypercarbic. Because we're limiting the volume and we're limiting the pressure, the carbon dioxide may go up. We allow that because we want to limit the volume-induced lung injury. PEEP is increased from age 8 to 15 to decrease to FiO2 less than 60%. Because we always think that if the FiO2 is more than 60%, you can have oxygen toxicity. So you try to go up on the PEEP and down on the PEEP depending on the oxygenation. Auto-PEEP is usually rare in ARDS or acute lung injury because the lungs is stiff. When you give them the ventilator breath, it just keeps on collapsing. So exhalation time is very quick. In ARDS or acute lung injury, you can see that even if it's diffuse, when you take a look at the CT scan, it's heterogeneous. There are some areas that are actually better ventilated, some areas that are more consolidated. And I think you see this with COVID. And this is the reason why they say that in ARDS or acute lung injury, we should ventilate them with a small lung or a baby lung, as what Dr. Gattinoni would say. With conventional ventilation, when you put them on high volume, you do not have alveolar distension. But in patients with ARDS, because there are some areas that are stiff, so some actually will have a higher pressure, and that causes in ventilator-induced lung injury, and this is the reason why we use lower tidal volume or protective ventilation. We want to avoid alveolar overdistension. We also want to prevent alveolar collapse, and this is the reason for PEEP. Okay, so you can have atelectasis trauma, which is alveolar collapse, or volute trauma, too much volume, alveolar distension. This is the safe spot where we usually want to put our patients on mechanical ventilation for ARDS. In patients with obstructive airway disease, the goal is to support oxygenation and assist ventilation until airway obstruction has improved. Potential problems include hyperinflation, auto-PEEP, and secondary hypotension. Because if you have too much auto-PEEP, so you have to be very careful with this patient when you put them on the ventilator. So usually the initial tidal volume is 8 to 10. Sometimes I use less, actually 6 to 8 most often. Stick with 8. That's probably the better one to start with. Minute ventilation adjusted to maintain a low normal pH. So shoot for pH again. Inspiratory flow rates are set to optimize the inspiratory expiratory flow rate. You want a faster inspiratory flow because you want a longer exhalation time. So the faster the flow, the higher the longer is your exhalation. You want the patient to exhale all the air out. It allows reduced breath stocking and prevent auto-PEEP. Okay, so just a review. In patients with auto-PEEP, you can see that the exhalation time doesn't go back to zero as in this case. And you can see actually here, there's an auto-PEEP with this machine because the exhalation time. And you have to either decrease your volume, that means you decrease your inspiratory time, so increase your exhalation time, or increase the flow rate, so it's faster, so you can decrease your inspiratory time, or slow down the rate, and of course, nebulization, steroids, etc. Asymmetric lung disease as well, you have to be careful with this because the gas will flow the path of least resistance. So the more compliant, the less stiff, air will go in preferentially there. So tidal volume is distributed to the less affected lung, which causes overdistension of the less affected lung and poor expansion of the diseased lung or injured lung, which can worsen the VQ relationship in both lungs. So, so you have to probably use a lower tidal volume in asymmetric lung disease. In patients with heart disease, the major goal is to decrease the work of breathing and ensure adequate oxygen delivery to the heart. Patients with congestive heart failure may also benefit from increased intrathoracic pressure, which will decrease LV filling and decrease LV afterload. High mean airway pressures may also affect cardiac performance by increasing right ventricle after reducing venous return. In most patients with heart disease, a little bit of PEEP will help. And this is the reason why sometimes in patients who have heart failure, you intubate them, they start to diurese. Positive pressure, either non-invasive or invasively, can help. Neuromuscular disease have intact respiratory drive and normal lungs and may require a higher tidal volume to avoid the sensation of dyspnea. So this is the last part, weaning. We'll just do this very quickly. When we say weaning, it is used to describe the gradual decrease of ventilator support. 40 to 50% of the time is actually dedicated to weaning in the ICU. When we say wean, it is to liberate the patient from the mechanical ventilation and removal of the artificial airway. Sometimes you have to keep the airway because of secretions or the patient still comatose. So you have to take a look at is the patient wean from the ventilator and can we remove the artificial airway. When do we wean? First, the primary problem causing the respiratory failure is improved. If the patient comes in with COVID ARDS, you cannot wean them unless the COVID ARDS is better. If the patient comes in with congestive heart failure or patients who are fluid overload from dialysis, once you dialyze them, you take the fluid, then you can immediately wean and take them off the ventilator. We can do subjective criteria for weaning or integrative indices: compliance, resistance, oxygen, rapid shallow breathing index. There's a lot of weaning indices actually available. So you can take a picture here, and there is more complicated like the CRAP index, the integrated weaning index with the core index. But what I would probably say is that the rapid shallow breathing index is probably what we use most often, and I would suggest that you remember. Rapid shallow breathing index in Harrison is called weaning index. It's frequency over tidal volume in liters. Frequency is respiratory rate. Vt is the tidal volume, spontaneous tidal volume in liters, and the number should be less than 105 or 100 if you want. So if you say that the patient is breathing at the rate of 30, the tidal volume should be more than 300 to get a rapid shallow breathing index of less than 105. Okay? This is very important equation. It is assessed with continuous positive airway pressure, a level of PEEP used during mechanical ventilation. The rapid shallow breathing index, which was discovered by Yang and Tobin. Yang was actually a Taiwanese immigrant. Tobin is his mentor. Still alive in Loyola, has a sensitivity of 0.97 and a specificity of 0.64. That means the low specificity suggests that even if your rapid shallow breathing index fails, doesn't mean that you can still extubate them. Some patients will still be able to be extubated, even because the specificity is poor. Winning indices, numerous objective indices have been studied to predict failure winning. None are sufficiently sensitive and specific to be useful in predicting the success of ventilation. What I would recommend is spontaneous breathing trial remains a de facto gold standard test to determine if the patient can be taken off the ventilator. These are official guidelines. You can probably read this. This is from the American Journal of Respiratory Medicine, January 2017. And there's also another guidelines published in CHEST in 2017. So take a look. We'll just briefly review this. But what they recommend is that all patients on the ventilator should be placed on early rehabilitation movement, because that will improve, facilitate weaning. We should minimize sedation, and that each institution should have a ventilator liberation protocol. So every day you should come in with a mind of taking the patient off the ventilator. Ventilation liberation protocols involve sedation awakening trial, taking them off their sedation every day and putting them on spontaneous breathing trial. More than 70% of patients are successfully liberated with just one try. Identifying the earliest point in time to conduct the SBT is the most important. So when do we adjust when the patient's ready for spontaneous breathing trial? It is reversal of the underlying cause of respiratory failure. If the patient has still bad pneumonia, there's no point in weaning. Adequate oxygenation of PEEP less than 8 and FiO2 of 50%. That means there's enough adequate oxygenation, the lung is better. Adequate pH, that should be 7.25. If the patient is still acidotic, there's no point in weaning. The blood pressure is stable. If the patient's hemodynamic unstable, what's the point of weaning? And then, of course, the patient's awake to initiate their own inspiratory effort. And this is the protocol they do. So every day they look at the spontaneous awakening trial, and this is a safety screen of failure. And then they go ahead with the spontaneous breathing trial, discuss how it's done. If it passes, then you consider extubation. If it fails, you back to ventilator support, and then that's what you call your weaning. You put them on SIMV or pressure support. So when you do a spontaneous breathing trial, you put them either a PSV mode of 5 to 10 cm pressure support ventilation or a TP trial. You put them on 30 to 120 minutes. If the criteria used to assess patient tolerance during the spontaneous effort is adequate, that is, the respiratory pattern is good, the equation of gas exchange, hemodynamic stability, and subjective comfort, some would do a blood gas after 30 to 120 minutes. I mean, it's good, then you can actually. Or you can combine what I do, I look at the rapid shallow breathing index when I put them on 5 to 10. If the rapid shallow breathing index is greater than 105, that means that it's failure, that the patient's not ready for extubation, then I put them on higher spontaneous mode, then I start weaning. Okay? So it is recommended by the American Journal of Respiratory Critical Care to actually to use the pressure support, though there is more failure with pressure support, but the recommended way to do spontaneous breathing trial is initial SBT conducted with inspiratory pressure augmentation of 5 to 8 rather than TPs. This is expert opinion. In patients with weaning, there's actually 3 types of patients we see. Simple wean, you do your spontaneous breathing, you extubate. These are patients with congestive heart failure or pneumonia that gets quickly better. Most patients, or stroke who wakes up, majority of patients, 69%. Low intensive care urinative mortality, 5% in hospital mortality. Some patients we define as difficult to wean, that is, you try 3 spontaneous breathing trials or 7 days, they still fail. That accounts for 26 to 39%. Then a minority will actually 6 to 14% where we need a longer ventilator days to set. So with difficult to wean, what we can do, there are 3 ways that you can wean this, either SIMV, pressure support, or daily TPs trial. As there are 2 randomized controlled trials looking at this. Esteban, published in New England Journal in 1995, what he saw was that TP's spontaneous breathing trial wean more quickly than pressure support, who win more quickly than SIMV. So TP is better than pressure support, but pressure support better than SIMV. In terms of, Bouchard et al. Also did a randomized controlled trial published in American Journal in 1994. What he did was he compared TP's trial with SIMV and pressure support. He found out that in his paper that pressure support is superior to TP's and TP's was superior to SIMV. They were saying that probably Esteban, which is in Latin America, is more comfortable with TPs. That is why they did better. While Bouchard in France were more comfortable with pressure support weaning. That's why they did better. But in all, the majority of patients, if fails with majority of patients could be successfully extubated after 2 hours of TPs or spontaneous breathing trial. If their weaning for initial trial fails, then they do not suggest that you do IMV wean because IMV wean for both trials actually fails. So you can do either PSV wean or intermittent TPs trials. So pressure support, you start with higher pressure support, then you keep going down until you get to pressure support of 5 or 7, then you extubate. There are also automated weaning modes, which are probably in your machines as well, depends on what machine you use. But the last Cochrane database says that there is no evidence that this is better than the way, old-fashioned way we do weaning. So in the prolonged wean, these are the more difficult patients. You may need to ask yourself, why is a patient having a weaning failure? So you look at the respiratory load, cardiac load, cardiac dysfunction, neuromuscular problem, central, peripheral. Could the patient have a unilateral diaphragmatic paralysis seen in CABG patients? Could be hypothyroidism, critical illness, neuromuscular abnormality because of prolonged stay in the ICU, neuropsychological factors, metabolic and endocrine disorders. Or the only thing you have to have a disciplined approach because sometimes it could just be electrolytes. Reversible lesions may become apparent or a co-pathologist made difficult to optimize or slow to resolve. So it may not become apparent initially, and sometimes it takes time for them to get better, like nutrition. There's a mnemonic that was suggested by the Respiratory Care Clinics North America, which is WINSNAP. So WISH, have you controlled the exacerbation in COPD and asthma? Sometimes it's small dose of steroids and bronchodilators. Has the patient's heart disease been adequately controlled? Optimized heart failure? Is the fluid overload still present? Electrolytes, especially phosphorus and magnesium and potassium and other metabolic or derangements like metabolic alkalosis can lead to weaning failure. Maybe it's just anxiety and delirium. Okay? Neuromuscular disease and weakness in critical illness neuropathy, patient must still may have with sepsis. Nutrition is one of the factors that we have to start when we think of a patient in the ICU. Opiates and other sedatives may need to be weaned off, and then think of thyroid disorders. So I hope I covered all the objectives, and I hope I did not bore you. And this has been a whirlwind lecture on mechanical ventilation. And I think you have to read on your own and see more patients. In the end, again, this is a bad time for all of us. And thank you, may I thank you for always be his willing instruments in this fight. Thank you. And that ends my lecture.